friends. I am Shrenik from Ahmedabad, stage 4 vocal cord cancer survivor, currently in my 28th year. And I am having a privilege of being a patient ambassador and moderator of Friday's Speech Shrenik live webinar. And today is our 14th session, which we are connecting every Friday at 6 p.m. Today we are having my dear friend and commendable medical oncologist ID experience and someone who has meticulously treated one of my very close relative about lung cancer. So, and the name is Dr. Ashish Kaushal. Is a visiting consultant at KD Hospital, Ahmedabad, and he has his own clinic that is Angan Cancer Care at Ahmedabad. Sir, welcome on board, and thank you very much for your valued time.
Thank you, Shrenik bhai. It's my privilege to be here. And this is one of the very good time because the November is the lung cancer awareness month, and you've chosen a very right topic, particularly this month, that would be a talk or awareness talk for the lung cancer.
Sir, before you continue, we would like to welcome you on behalf of Indian Cancer Society and myself with this small, digital bouquet. So welcome on board and thank you once again for your valued time.
Thank you.
Sir, kindly proceed.
Sure. So as I mentioned, November is the lung cancer awareness month. Last month we have been discussed about the breast cancer. That was October was the breast cancer awareness month. Unfortunately, the lung cancer is very lethal and aggressive cancer, and it is very important to know how to reduce the risk of lung cancer and how to diagnose this cancer in very early stage because this is very aggressive and fatal cancer. So let me share my screen. I hope my screen is visible, right? Yeah. So what we are going to discuss about is the personalized treatment of lung cancer. So as I mentioned, the lung cancer is very important because this is one of the common cancer in the world, and mostly the incidence is one of the highest in the Western world, and in India, the cancer is also one of the top 5 cancer. Uh, what is important for lung cancer is the beginning would be a prevention. Any of the cancer, if we can prevent, that would be the best thing. And in lung cancer, there are the scope of prevention because this is the cancer which is more commonly associated with our lifestyle, especially with the smoking. So any source of tobacco, whether it is a smoking form or oral tobacco, or any environmental risk related to the occupational hazards, whether it is tobacco or any other heavy metals or the cotton worker or diamond worker. So all of these are risk factors are associated with the increased risk for this cancer. And besides the screening, there are the role of therapeutic strategy. We have tobacco quitting programs, and that is not only for the psychological aspect. We have the pharmacological interventions where the psychiatrist and the, the the behavior therapist is counsel for this patient how to quit these addictions. Not only the tobacco, the alcohol, everything is can be a risk factor. We have the screening program for the high-risk individual. Nowadays, there is some definitive guidelines, and these guidelines are basically to help in the screening. And because the lung cancer screening is not worldwide accepted, so how to do the screening and what are the tests that we are going to discuss and subsequent slides. And if somebody is having the diagnosis of the lung cancer, I think the important thing is how to treat this cancer and to prevent the recurrence, because the lung cancer is known for the progression even after the multiple line of treatment. There are the role of common modality treatment most of the lung cancer patient, but there is need of diagnosis of the cancer in the early stage, because once the stage is increases, the cancer outcome is going to be compromised. Uh, those patients who treated with some local treatment, especially with the surgery and radiation, there are the quality of life issues post treatment. So I think that is also very important after the treatment. And the last, that would be a palliation, because in those patients, the cancer cannot be curable. If they diagnose in the advanced stage, unfortunately, in our country, a lot of patients have been diagnosed in advanced stage. So there is the role of palliative care and how to manage the symptomatic treatment, that is important. And those patients, they have been advanced cancer, we have to look for the hospice care, and the use of the pain relieving and the supportive treatment is very important, because this cancer is an advanced stage, is not curable. If you see the incidence of lung cancer and the prognosis, this is the fatal cancer. And unfortunately, majority of the cases are diagnosed at the advanced stage. You can see in this slide. Uh, so if you can see in this slide, the majority of the cancer, that is around 60% of the patient, they actually were diagnosed in the advanced stage. And as the stage go beyond, you can see the outcome is going to be compromised. In localized cancer, we have a half of the patient can get a more than 5 year survival. But if you go beyond, it is less than 10%. Once the distant metastasis is less than 5%. So the stage is very important. And there are the certain factors, which is the biological factor that we'll to discuss further. But the important thing is it should be diagnosed as early as possible. And if there is a prevention, that would be the great. So globally, this cancer has been diagnosed in early stage around half of the patients. So that is the stage 1 to stage 3. But if you see in our country, still the majority of the patient, it is more than 50% patient, they actually were diagnosed at advanced stage. That could be a stage 3B or stage 4 patients. So in this stage, this cancer cannot be cured. So we have to give the systemic treatment, that would be a medical management, and we need to prolong the life of this patient. We have to control the symptoms. So diagnosis of the cancer in early stage is very important, even with advanced stage, because most of the patient, they presented with non-specific symptoms like cough, chest pain, or weight loss, and those kind of the symptoms. They treated with some kind of the local treatment and anti-cough treatment, and some treatment is going for longer duration, like somebody is treated for the TB medicine, antitubercle therapy. So few months they have been passed once they reach to the oncologist, and when the diagnosis has been made, and that the stage goes from localized to the metastatic stage. So early diagnosis is very important in lung cancer. There are the role of the clinical and invasive staging. So basically, whenever the cancer has been diagnosed, we have to be go for a proper staging, because sometimes what happens, there are some lymph nodes in the chest which can be infective, and it could, or it can be malignant. So we have to differentiate it whether it is really a cancer spread or not. So the combination of the pulmonology and oncology collaboration is important to diagnose the exact stage, early detection, and how we can improve the cure of this patient is very important. So proper staging, not only the radiological criteria, we have to look for the pathological criteria and the several cases. When your scans are showing some lymph nodes in the chest, like that is a mediastinal node. So we need to look for the proper staging, and sometimes what we need to do some biopsy of those lymph nodes to exactly diagnose the lung cancer. So somebody has been diagnosed with a lung cancer. I think the common histopathological type is the non-small cell lung cancer. So majority of the lung cancer are actually non-small cell lung cancer, and there are also some subtypes of non-small cell lung cancer, that is adenocarcinoma or squamous cell carcinoma, the common. And other less common cancer is the small cell carcinoma, that is around 15 to 20% cases. And this is very aggressive type of lung cancer, and this requires proper diagnosis, and most of the patients are diagnosed in advanced stage. What are the common tests for lung cancer? We need to do a simple X-ray because whenever there is a symptom, the common public will go to the local physician or specialist. They do the X-ray test, and this X-ray sometimes is helpful in the diagnosis of the lung tumor. If there is a big enough to diagnose with the X-ray, then they can refer to the specialist and they do some more investigation. The investigation of choice for the lung cancer is the CT scan of the chest and with contrast, so that can be helpful in COVID time. A lot of HRCT has been done for the COVID scores. So at that time, a lot of incidence of the lung cancer is increased because of this more scans. And the further staging would be done by the PET CT scan that helps in the diagnosis of the cancer, whether it is spread beyond the chest or not. So PET scan help for the exit staging. Sometimes PET scans helpful in the diagnosing the lymph nodes in the chest. So that also helpful in the diagnosis of the stage, and later on we can biopsy those of the lung cancer spread, and we can confirm the metastasis. MRI in lung cancer mostly we do for the brain metastasis, because sometimes what happen, there is a suspicion of the brain metastasis, so we can get MRI done and we can diagnose with the brain metastasis. And as I mentioned, the biopsy is the test which we can diagnose the lung cancer, and subsequent typing, whether it is a small cell carcinoma or whether it is adenocarcinoma, squamous cell carcinoma, that we need to do a IST, that is called immunohistochemistry test, which can be done on the biopsy slides and block. So once the cancer has been diagnosed, once the scan has been done, we need to do some more profile, that is called molecular testing and PD-11 testing. That's helpful in the decision of making the what kind of the therapy we need to give for that particular patients, and that is called the personalized medicine. So treatment as per the molecular and the profile of individual cancer patients, we need to give the treatment, and that's helpful in the proper outcome of that particular patient. So now we have this, all these tests are available in our country, and we do most of the patient with proper diagnosis, and we do the molecular testing and PD-11 testing, and we can get a proper treatment for most of our patients. In general, the treatment modality of the lung cancer, we have a surgical treatment like surgery of the lung. It can be open surgery or video assisted or robotic surgeries. That surgery includes removal of the lobe which contains the tumor, or removal of the lung on the one side, or sublobar dissections. We have a radiation facility like 3D radiation, IMRT, IGRT, stereotactic radiation, or proton therapy. These are the different kind of the radiation for the lung, and most of the patients require systemic therapy. That will be chemotherapy, targeted therapy, immunotherapy, or combination therapy in most of the patients. So these are the, in general, this is the broad topics for the treatment modality, and majority of the patients require more than one modality of treatment. As I mentioned initially, the lung cancer, the 5-year outcome is better if we diagnose in early stage. If it is stage 1, there is 85 to 90% cure rate. But as the stage go beyond, the outcome would be 60%. With stage 2, stage 3A, it is 36%, and stage 4A, it is around 10%. Stage 4, it is the 5 survival is 0%. So diagnosis early stage is very important for lung cancer. Now, as I mentioned, and today we are focusing on the personalized based treatment and how to do the personalized based treatment for individual cases. So we have a certain cases which helps in just to give an idea how we can treat a different scenario. I have taken the scenario of the pre-cancer stage to the cancer stage. So let me discuss about the first case. This is a 65-year male patient who presented to the pulmonary clinic to rule out the lung cancer because he's having the history of smoking. So this is very common, So the smoking is very common in our country, even Western world. So those who is having a duration of the history is more, a lot of uh, 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 smoke cigarettes or BD they are taking. So sometimes they feel some symptoms like bronchitis, coughing, and in those patients they have been risk of cancer. They usually consulted, and sometimes what we see, these are the patients consulted the pulmonary clinic. So this is the classical example of those patients where they want to rule out whether they're having a cancer or not. So how we can decide which patients require the screening, what are the tests to be done, what are the frequency, and does the Western guidelines is applicable to the Indian patients. So the answer is we definitely we need to do the screening of those patients which are in the risk stratification wise high risk patients. So this is the general recommendation. You can see high risk patient, which is usually a elderly patient taking a more than 20 or more pack year history of smoking, and these are the patients which is considered to the high risk. But there are the certain patients which are the low risk, where the patient taking less smoking. But if they are symptomatic, I think they should still go for the lung cancer screening. But the routine screening is basically for high risk patients, and these are the patients there is a more history of smoking, not only for the quantity as well as the duration. And the test which is to be done is a low density CT scan, which is the recommended test. So general X-ray is not a screening modality. We have to do a CT scan. And once we do the CT scan, and based on the CT scan report, the oncologist will do a further test based on the report. So if somebody is having there's some nodule in the lung. Suppose if it is less than 8 millimeter, they don't require any further workup. They have to just go a routine follow-up every 6 monthly. But if the nodule size is more than 8 millimeter, they need to do a close follow-up, and it could be a 3 monthly or 6 monthly. But high-risk patient, those are the patients which is the size is more than 8 millimeter, I think, especially. Then they need to go for a more close interval, and they may require a biopsy, especially if there is a symptomatic like a weight loss and they have a persistent cough. So, and somebody is having the bleeding, that is called hemoptysis. So those are the patients we need to get it done. So these are the results based recommendations. So we need to do the for the steps, the workup for the high risk individuals, especially the tumor size is more than 8 millimeter. So this is the second scenario where the 65-year male with a history of cough with the right side pain on and off, they are the smokers and having X-ray done by local physician, and they have been diagnosed with the opacity in the lung. You can see in this X-ray film, there's a right side. You can see there is a lung nodule, and this is the area of the concern. And for that, they need to investigate further. And somebody is having this kind of the nodule or any other nodule in the lung, and they have a history of long studies, smoking, I think they need to investigate further. So these are the recommendation. Those having the suspicious lung nodule, we need to discuss this with among the MDT, and we need to look for the tobacco cessation counseling. But based on the risk factor, whether what are the age of the patient, smoking history, any history of cancer, family history, occupational hazards, other lung conditions. So based on that, we need to investigate it. And this is the simple example of how to go for further if there is some lung nodule. So ipsilateral, one single nodule, if the size is more than 15 millimeter, this is a high risk. And these are the recommendation we need to go for. We need to go for a CT scan and the PET scan. And if there is a still suspicion, we need to go for a biopsy or surgical excision if there is a very small nodule. So for if there is a single solid endobronchial lesion, we need to do the low density CT scan monitoring. But if there is a size is more than 15 millimeter, high risk of suspicion, we need to go for a proper biopsy or surgical excision if it is not biopsy. Because sometimes what happens, the lung nodule deep in the lung, you cannot do the biopsy because there is risk of pneumothorax, that is air in the lung cavity. So we need to get it done by surgical excision by doing some thoracoscopic procedures. The third scenario would be a situation where somebody is having a diagnosis in the lung, like the patient having the cough with the right side pain, smoker, but there is a definite big size lung mass and there is some spread to the surrounding lymph node. So this is the scan of this patient. You can see this is the PET scan. Basically, it's showing the lung mass and the involvement of the lymph node, which is surrounding to the respiratory tract. You can see this is the bronchus and this is the lymph node, which is the ipsilateral node. So these are the patient of the lung cancer, right lung, with the spread of the cancer to the mediastinal node, spread showing a clear shining uptake. So in this situation, it is ipsilateral lesion, so the surgery can be done. But nowadays, with the recent data, we need to give the neoadjuvant therapy, that would be chemotherapy and immunotherapy, and now which have a survival advantage, and that gives a superior outcome. And these are the patient after the 3 to 4 cycles of immunotherapy and chemotherapy that will be undergone the surgery. And those patients who go direct surgery, they require adjuvant chemotherapy or immunotherapy or targeted therapy based on the results. And those patients, there is a surgery is not possible because some patients, the lung condition is very poor because of the COPD. The lesions is quite big. So in those situations, we need to treat with the chemoradiation, and the chemoradiation would be a combination of radiotherapy with chemotherapy, and this treatment will typically last for 6 months, 6 weeks. Some patient, the spread of the lymph node in the other side, that is called a more stage. And these are the patients are actually inoperable, and these are the patients we need to treat with the chemoradiation followed by immunotherapy. So in some patients, we do the neoadjuvant therapy if the patient is not a candidate for upfront radiation because of the big size. So if you diagnose the cancer in early stage, surgery is possible, but majority of the patient, there is a stage 3 or stage 4, we cannot offer the surgery, and then we need to treat with the medical management or radiation treatment in stage 3. This is the case 4. The similar symptoms, cough and right side chest pain, smoker, but in this time, this X-ray is showing the lung mass with the bilateral lung nodules. So you can see in this X-ray, there is a big lung mass. There are the lung nodules. You can see this is the round nodules in other lung also. So this is the cancer which is spread not only in the same lung, you can see in the other lung. So CT scan will show lung mass, bilateral lung nodules with the mediastinal node, spread of the cancer to the right adrenal glands, and there is some spread to the bone. So this is the typically stage 4 cancer. We need to do a biopsy, and this biopsy is done for this patient, and this showing of adenocarcinoma. And after the biopsy, we need to do some more tests. And this is very important because nowadays, unlike the previous decade, we have only option of chemotherapy. In current era, we have a various treatment options. And based on the biopsy report, we need to do the further tests. As I mentioned initially, there are the tests like a molecular profile and a PDL1 test, which is available. And this test is helpful in getting some kind of the driver mutation. And if those mutations are positive, we can treat with the patient with the targeted therapy or immunotherapy if the PD-L1 score is high. So in lung cancer, by doing this comprehensive genomic profiling, that is called NGS, we need to tailor the treatment based on the various actionable mutation. So these are the list of the mutation, and one of the common mutation is called the EGFR mutation. So somebody is having this mutation is positive, we need to give the targeted therapy. So not all lung cancer patients require chemotherapy now. If there is this mutation like ALK mutation is positive, EGFR or MET, or the Roche one, these are the mutation positive, we need to give the targeted therapy. And this targeted therapy is a oral pill, and this is to be given daily, and the patient cancer can be controlled with this medicine, and the patient can survive for many years. Especially the ALK positive patient, they have a very good prognosis with the modern therapy. And even EGFR patients, we need to either give this only oral therapy, or we can combine with this chemotherapy. And in some patient where there is no driver mutation is formed, and if there is a PD-L1 score is high, I think we can give only immunotherapy, that can be an option. And otherwise, we need to combine chemotherapy and immunotherapy if there is no driver mutation is found. So combination therapy in most of the patient, but in some patient, like there is a driver mutation, we need to give the single agent target therapy with the which are available in the oral tablet form. So in current era, we have a various treatment option based on the individual patient profile, and this profile is easily available. Most of this test is being done on the biopsy blocks, but also now we have some liquid-based test, which is called a liquid biopsy, and based on the patient blood sample, we can do this comprehensive genomic profile, and we can get this mutation testing done, and based on the result, we can tailor the treatment based on the individual patient profile. So this is now available in our country easily. If you talk about the treatment options, based on the results of this test, either this patient is required a targeted therapy, immunotherapy, or chemotherapy, and most of the patients, as I mentioned, they require combination therapy, like combination of target therapy or immunotherapy, or target therapy or chemotherapy, or immunotherapy and targeted therapy. So various options are there, and based on that, we treat with the cancer, and we can get a proper outcome. So this is the last case, which is a different cancer. This is the patient having a cough dyspnea, and the patient having a PET scan done, which showing the lung nodules with the metastasis. But this time the biopsy showed a small cell cancer. So small cell cancer, I mentioned, it is a less common compared to the non-small cell, but is a very aggressive cancer. You can see in this particular PET scan. So this is the primary lung, and you can see this, all the black spot is basically the cancer spread. You can see the spread in the liver. This is the primary lung mass. This is spread to the bone. So small cell cancer is more than two-thirds of the cases. It is usually diagnosed at advanced stage, and these are the situation we need to give the chemotherapy and immunotherapy with this cancer. And these are the patients, there is no driver mutation based treatment is available. So we no need to perform this NGS testing or PDL testing. If there is biopsy is small cell cancer, there is a spread after doing a PET scan, then we need to straightforward start with the chemotherapy and immunotherapy. But in rarely, if there is a cancer is still limited to the lung, we can treat with the chemotherapy and the radiation, and we can give the consolidation treatment after the chemo radiation. But if the patient is diagnosed with advanced stage, we need to treat the chemotherapy, immunotherapy, and this cancer is to be diagnosed in as early as possible. So what we can give the message, there is a need of early diagnosis of the lung cancer because this is the very aggressive and lethal cancer, to improve the outcome, because in our country still the majority of the patients are diagnosed at advanced stage. Those individuals having a high risk of smoking, I think they should go for active lung cancer screening program. They have to consult the local physician, especially the pulmonologist, and based on the risk profile, the family history, occupational hazards, and individual risk criteria, I think they need to go for a active screening. And as I mentioned, low density CT scan is investigation choice for those patients. In some patient, there is still the diagnostic diploma. We need to do a confirmation by biopsy. FNAC is not a treatment of investigation of choice. We need to do the biopsy because biopsy gives a tissue, and that tissue can be done for further testing. That would be a molecular profile and PD-L1 testing. And this profile helps in the further treatment of that particular patient, and we can personalize the treatment whether this patient require chemotherapy, immunotherapy, or target therapy based on those results. Now, even with the advanced stage, we can get a better outcome as have been showed in the slide. If somebody is having the driver mutation like EGFR or ALK mutation, then we can treat with a targeted therapy. And I have some patient, they have survived more than 5 years with this medicine. So lung cancer, initially a decade earlier, if there is somebody is diagnosed with lung cancer with the stage 4, majority of the patient going to die within 1 year. But now with this modern therapy, with the personalized medicine, with the this test, we can prolong the survival with the many years with this patient. And even with a high PD-L1 patient, we can treat with this patient with immunotherapy. And the immunotherapy, the best part is basically is almost a negligible side effects. And this immune improves our immune system, and this immune system will take care for the cancer. So immunotherapy is also now available with us, and I think those patients having a high PD-L1 profile, they can be treated with immunotherapy. Otherwise, we need to combine with the chemotherapy, provided the RBN mutation is negative. So these are some cases I have been mentioned. Was for understanding, because the lung cancer having the patient profile is different to different. They have a different type of lung cancer I mentioned, non-small cell and small cell. And I hope this gives us some idea how to look for screening and early diagnosis, and to treat the patient based on a different profile. This I thanks to everyone, and I would be happy if there is any question in the chat. Thank you. Over to you, Shrenik.
Thank you. Thank you, Dr. Ashish. Friends, I know Dr. Ashish Kaushal for more than 10 years. I mean, those who have joined later on. So I am sharing these details. I know Dr. Ashish Kaushal for more than 10 years, and he has treated numerous number of patients. I have seen him, including one of my very close relative, particularly about lung cancer. Now, why we are conducting this kind of webinar and inviting super specialists like Dr. Ashish Kaushal, because they've got a lot of exposure, experience, and knowledge in treating various types of cancer. And another important thing is, particularly we at ICS, we are not doctors, but we are and we cannot be doctor either, but we are putting on our best efforts to invite specialists like Dr. Ashish Kaushal for sharing their knowledge so that you can get a better idea of any cancer or any disease related to cancer stage 1, 2, 3, 4, or any organ cancer. Now, sir, coming back to you, I would like you to explain a bit more into detail about PDL1, and then I have a few more questions as well.
So basically, PDL1 is a test is to be done on the biopsy tissue. Basically, this tells test helpful in diagnosing whether how immune is the tumor. So like any of the cancer cells, they activate, they spread because of the some suppression of our immune system. Because somebody is having a normal immune system, the cancer cannot grow easily, and if their immune system has been suppressed, then they can get a cancer and they can spread to the different part. So there are the various pathway, and these pathway are important in regulating that balance of immune system. So the cancer release some substance which is called some antigens, and these substance, which is our protein substance, they actually suppress our immune system through various pathway, and that is one of the pathways called checkpoint pathways or PD-L1 pathways. And because of that pathway, they suppress our immune cells that is called T lymphocytes. And if the T lymphocytes is been suppressed, our body, our immune system cannot kill the cancer cell. The cancer cell can bypass those things and they can protect it. And these immune cells is in the suppression state. They cannot protect the cancer to spread further. So if we can block those pathways, which is called PD-L1 pathway, by giving a various medicine, which is called immunotherapy drug. So there is a two medicines, which is called, one is called PD-1 inhibitor and another one called PDL1, which is a downstream pathway. So if we block those pathways, so what is going to happen with this medicine? The suppression of our immune system has been removed and our T lymphocyte become active. So once the T lymphocyte is been active because of our immune system, so this medicine doesn't cause any cancer killing. So basically what this medicine does, immunotherapy, they remove that suppression, and after removing the suppression, then the cancer cannot suppress our immune system. Our immune system become active, and our immune system can kills the cancer cell directly rather than any drug is required. So because of this immune therapy, our PD-PDL1 pathway, which is activated, has been suppressed. But basically, this is called PD-PDL1 inhibitors, these immunotherapy drugs, and our immune system they can activate it, and immune system can control the cancer. And those patient this is more activated, they can better control. So we can get the level of expression by doing this test. So if the expression of PD-L1 is high, there is a high chance this patient is going to respond with immunotherapy. This is the logic of immunotherapy.
Thank you. Sir, I remember one of my conversations with you last year about, prescribing the specific drug, I mean, immunotherapy or chemotherapy drug, which is not kind of a generic drug, but base brand available in the Indian market. I would like you to share your experience on this particular aspect because 20 times for the cost saving purpose the chemotherapy or drugs are given which are not of a superior quality, and that is causing another problem and for recurrent cancer, etc. So kindly share your thoughts on this.
So, fortunately, now we have a better diagnostic tools are available. As I mentioned initially, this is the NGS testing, which helps in the diagnosing whether there is any driver mutation. So, if the lung cancer patient having those mutations are there, we can target those mutations with the medicines which is available now. So there are the various mutation. There is a mutation as most common mutations in lung cancer is EGFR mutation and ALK mutation. There are the other mutations like KRAS mutation. Uh, there are the Roche one. There is a MET, NTR. It's a different mutation, but the common mutation is the EGFR and ALK. And fortunately, which is most can be treated with a targeted drug. We have these drugs are available. So what you are talking is about the EGFR mutation, and this is the most common mutation. And even EGFR mutation, there is a various different mutation like exon 19 mutation, 20 mutation, 21 mutation. So the different target medicine works for different mutations. So somebody is having an exon 19 mutation of EGFR, they can be treated with the 4 5 treatment options of targeted therapy, and all are available in India. And one mutation called exon 21 mutation, they can be also treated. So these targeted agents can be given as a single agent, or in some patient, like in metastatic stage, we need to combine with the chemotherapy in some state. So we have a different generations, like first generation, second generation, third generation medicines available. And as the generation go beyond, there is just some cost and the factors there added. But even there are the certain medicines that are available in a costing of 1,000 rupees per month, which is cost effective with the if there is EGFR mutation is positive. And there is some medicine costing for 1 lakh rupees per month also. So based on the mutation, based on the generations, we have a different medicine. But the important thing is that with this mutation, we can treat with the oral target therapy for cancer patient, even at stage 4. And in some patient, we can give in an early stage, in stage where they have been operated and the mutation positive, we can give the single therapy as you are one of the patients taking rather than doing the chemotherapy. So with this mutation, we can treat with the cancer with the oral tablets rather than chemotherapy. And some of the patients where the combination therapy is required, we can combine with this targeted therapy along with the chemotherapy also. Having said that, there are the certain other types of mutation like ALK mutation, Rochman mutation, where we need to give a single agent target therapy, and we have a various single agent drugs are available in our country, and these patients can survive for many years, especially for ALK mutation or fusion positive patients, and they do very well with this therapy. So now the lung cancer treatment is totally been changed in the last few years. And besides chemotherapy, the target therapy, immunotherapy has been there, and we can give the better outcome and good quality of life and best survival for this patient nowadays.
Thank you. So, people, that is one question in chat box, but for the benefit of the audience and listeners, I would like you to share a bit about, the strategy of pharma company for cost saving, so that, they can get advantage of the not spending a lot of money while getting immunotherapy or chemotherapy. If you like to answer my question, please.
So basically, our country is a developing country, and compared to the Western world, most of the patient cannot afford the immunotherapy drugs. So for our country, the various pharma company has been initiated some kind of the programs, and that is called a patient assistance program. And this PAP program, this is patient assistance program, has been there mostly for all immunotherapy drugs. And so unlike the Western world, they have been made available for this program, and so that the drug can be reachable to most of the patients for the not only for lung cancer, for rest other cancer where the immunotherapy is there. And this immunotherapy drug actually is out of the pocket for most of the patient, but they have been cut down the prices with this PAP program, so that some schemes are there. You can just purchase 5 vials and you can give the entire year of therapy, or 1 cycle, then 2 cycle, three or 3 cycles. So different programs are there for different indication. But now this the price has been slashed, like a lot of patient can afford. Same thing with the targeted therapy, because some of the target therapy, as I mentioned, are expensive, but they have been cut down the prices by doing this program. And some of the program is based on the financial part of the patient, so the family income, those kind of things they also consider. And in some programs, they can give the free treatment also based on the profile, especially that is also possible. So I think currently every patient should receive the proper medicine, and they try to look out. And with the PAP program, the patient can get this medicine, which is reserved for the patients.
Thank you. Friends, well, I have asked this particular question for your own benefit so that no, you don't spend a lot of money without knowing. So this is the information I wanted Dr. Ashish Kaushal to share with you. Vaishali, please proceed with the questions from the audience.
I think one thing has been mentioned in the chat box that what should be the age criteria or when to start the screening. I think that has been already mentioned in my one of the slide. Usually, the lung cancer screening start after the age of 50, and especially for high risk individual. But as I mentioned initially, those having a very strong family history or addictions is young, they are symptomatic. I think there is no age. Even the young age, we see a lot of patients, even the middle age, 30, 40, 45. So I think somebody is having more addiction, they are in high risk. There is no cutoff age. They should be consulted their local physician or oncologist if they are symptomatic. But the important message is basically we need to quit those addictions which is causing the lung cancer, because these are the addictions, especially for tobacco or alcohol. They're not only causing the lung cancer, they're causing a lot of other diseases, especially for cardiovascular diseases, strokes and heart problem, even lung problem. So I think which is more common compared to the cancer, but I think the addiction should be stopped as early as possible. But so the screening of lung cancer, I think we should be start once the patient is symptomatic, and in there is high risk individual. I think the 50 is at least the age we should start screening.
Thank you. Sir, one more question. You mentioned about small cell cancer. What is the survival rate? Number one, and how many years in general patient who is diagnosed with this will survive or the survivorship?
So small cell lung cancer is not that common as I mentioned in compared to small non-small cell. This cancer is very aggressive. So most of the patient diagnosed in advanced stage, majority of the patient. But if they're diagnosed, luckily in the early stage, I think it's chemo radiation. In some patient, the surgery can be done if they diagnose stage one and early stage two. But in our country, majority of the patients require chemotherapy and immunotherapy if they can afford, because there is a spread of the cancer. Then you need to treat with the medically. Life expectancy, if with the current medicine, I would say, when somebody is diagnosed with stage four, the usual life expectancy is around 1 year. So 10 to 12 months with the treatment. And if you don't treat, I think the survival is less than 6 months. So this is very aggressive. But the one important part of this cancer, this is very aggressive. So at the same time, responded very rapidly to the treatment. So if somebody started chemotherapy, the cancer responded very well within short period of time. But at the same time, the relapse also come very fast. So this should be treated aggressively. And with the immunotherapy, the outcome is improved because of the small cell lung cancer and stage four, the immunotherapy has been added. There are some recent data where the patient who treated with the chemo radiation, if you add immunotherapy, the survival is almost double. So that is still going to be, I think, approved. But I think the immunotherapy is one of the game changer for this particular type of the cancer also. So this is but I think should be diagnosed as early as possible.
Right. Thank you. Vaishali, is there any more questions?
No, sir. On YouTube, there is no more questions. And if participants have, they can ask questions. You are free to unmute yourself one by one and you can ask. Anubha, please go ahead.
Sir, oh, yes, Anuba, unmute yourself and ask.
Thank you, sir. Thank you, Vishali. Thank you so much, sir, for this wonderful talk. It was very informative session. So I have one question that is little bit different from the conversation that we had. It's regarding the rising rate of the cancer patients, especially because we know lung cancer is always comes with very terminal stages or highly aggressive treatments not available or last stage. तो इसके लिए being a cancer NGO and being a as you are actively interacting with patients and you know the technical part of this type of cancer, so what can we do as a society? What are the things that what are the steps we can take to prevent the cases or to spread the awareness or anything that we can contribute?
Yeah, I think this is very important, Anuva. I think you have pointed out the right thing because the treatment is basically for those patients who's present in advanced stage. So the important thing is one is the prevention because this cancer is very aggressive cancer. So the important thing is prevention. If we prevent this cancer, and because a lot of patients it is associated with the addictions, and in female, I think there is the cases is secondary to the second hand smoke. So the husband is smoking,
Yeah.
and
Yes,
course,
passive
that
smoking.
smoking is called passive smoking. That also contribute. So that's another factor. I think not only they are increasing the risk of their other family members, they are at high risk. So I think that should be targeted because if somebody cannot cut down, the other family member has to encourage to quit the smoking, and because that is causing not only the risk of other family member and even for the society. And that's why the government banned this kind of the addictions at the public places. And the second thing is the factory and occupational hazards. So because a lot of health have been compromised if somebody is working in those environment where there is occupational factors are the fumes and the patient having some factories and the cotton worker, diamond worker. So those things are been associated with the lung cancer. I think that can be properly taken care because that helps in the prevention of those things. Second thing, as I mentioned, is the early detection because lung cancer patient they usually treated with initially with the local physician, pulmonologist, and a lot of patients receive anti-tubercular therapy. So I think the delay in the diagnosis, that upstage, so that is another important area which is to be targeted because somebody is not responding with a conservative treatment. It is not like that everybody should refer to the oncologist, but somebody the symptom is not classical, they're not responding with a conventional treatment, empirical treatment of antibiotics and anti-tubercular therapy. I think this should be very should be done with caution because a lot of patients they have been treated 2 3 4 months 5 months anti-tubercular therapy, they're not responding and then later on diagnosed. So I think most of the patients they get the response within few weeks, and if somebody is not responding, I think they should be because if there is a diagnosis not confirmed, they're taking empirical treatment. I think the physician should be on very much close follow for those patients because if the patient is in default, they come with advanced stage. So I think diagnosis should be done as early as possible. And we have been because COVID has been given a lot of awareness, especially for the diagnostic test. HRCT facilities available in all the tier one, tier two, tier three, even a small district is it is available. It is very cost effective now. So I think this is should be done if when there is a suspicion of cancer. I think we should not miss any of the lung cancer in early stage.
Thank you, sir. And sir, also ये pollution, मतलब as you know, in Delhi, we are in Delhi, and the pollution is just keep rising. It is not.
Absolutely. I think the government is very, very aggressive for that part. And I think, lifestyle, because its pollution is not because of the anything. It is because all of us
Yeah,
are contributing.
we
So
are
I
the
think
contributing
the
factor.
government policies are very, very, very aggressive. And I think this should be come down. And I think we have to take the proper precautions as because we can't do any other thing. And N95 masks, those kind of thing. And that is also
Okay.
important.
Thank you, sir.
So aligning with what you said and what Anuva she has asked, I mean, these smokers, you know, uh, it is my generous appeal to every smoker that if you love your family, if you love your kids, please quit smoking, not for yourself and kids.
Absolutely.
Sir, I guess there is no other question as of now. We thank you very much for your valued time, giving a lot of details, lot of information. I mean, which is rather which cannot be made available to general public even during private consultation because of the doctors too many priorities. So we really value your time and sharing all information, and we look forward to having you once again, maybe for another type of cancer in the near future. Thank you so very much.
Sure, absolutely. It would be love to participate. Thank you. Thanks for your invite. Thank you. See you. Bye bye.
Thank you, Dr.
Right.
Ashish. It was very wonderful and informative session about lung cancer. Thank you, sir.
Thank you. See you. Bye.
Thank you.